Thank you, Dr. Compton. We take questions. Will?
I had one quick question. In terms of your adjustments, one of the one of the one of the concerns I had is when I looked at the differences in cases and controls was the lower proportion of cases who actually gave consent to get a blood sample and so forth.
Yes.
Did you consider, again, instead of just regular kind of just adjustment in regression analyses, a propensity score analysis, to be able to take into account some of these potential differences?
We traditionally try to account for non-consent.
Microphone.
I said, usually when we do this kind of work, like with the controls, we will try to adjust for non-consent. We'll do a little mini study to try to convert refusals. That wasn't possible for the hospitalized. There were various reasons. I mean, obviously, if somebody was severely injured or unconscious, we tried to get the hospitals to do a blood draw and hold it until we could get consent, but not all the hospitals, I think there were 5 in Virginia Beach, would agree to do that. So the answer to the question is no. Though we actually have another study afoot. When this one was done and I was surprised at the results, I spent some time thinking, if I was someone else and saw this study, what would I criticize it for? And I came up with lots of interesting things, like maybe if we had only looked at what one might call more severe crashes involving death or injury, the results would have been different. Lots of things. So we're actually doing another similar sort of study involving only injured, seriously injured people transported to hospital or that died in the crash.
Okay, Dr. Williams.
Thank you for your presentation. I have a question about the driving-related skills studies you were citing. What dose of cannabis were they exposed to, concentration, and how long afterwards were those skills measured? And then for the case control study, you're detecting THC in cases and controls. What does that tell us about when they were exposed?
Okay. The first part of your question, in a dosing study, I think they traditionally use like a 3.5% cigarette they get from DEA, NIDA, or 6%. It is not routine in this kind of these dosing studies where they do blood draws. Okay? So you don't actually know what the THC level is. And while there are attempts to standardize consumption, you know, like they'll have metronomes, they'll ask people to inhale at certain points in time. The last study we did, again, actually in conjunction with NIDA, we tried to get really fancy with our dosing and imported a volcano device, a vaporizing device from the Netherlands, where you basically incinerate the marijuana materials into a mylar balloon, and then you attach it to the equivalent of a gas mask so the person just naturally, and we had different doses in the cigarettes, and we were very surprised that when we looked at blood levels, because Marilyn Eustace, who's now retired from NIDA, was partnering in this study, and we put a line in and took blood repeatedly for 6 hours after dosing, that in many cases the actual blood levels were no different between the low and the high dose. So these subjects were perfectly capable in ways we could not understand to titrate. And I think this has to do with how deeply they inhaled, how long they inhaled before they exhaled. Now, of course, these subjects were regular marijuana users, and they apparently had their preferred high, and they got it regardless of the percent THC in the cigarettes we were using to dose them. So what I'm saying is there is a huge amount of individual variability, and it's despite experimenters' attempts, I think you achieve very different dosing levels. in these experiments, but unfortunately most of them don't actually measure blood levels, so that's unknown. The second part of your question is we were measuring the presence of THC. I have come to the conclusion, unlike alcohol where blood alcohol concentration, breath alcohol concentration, when you look at the normal curves and you plot on the same graph impairment from many different kinds of impairment, there's a high correlation. As BAC rises, impairment rises. As BAC declines, impairment declines. There is no such correlation between THC levels in the blood or in oral fluid and impairment. When someone is administered, self-administers cannabis through smoking, you reach peak THC typically right near or at within minutes of the end of smoking. Okay. The pharmacokinetics of the elimination of alcohol, for example, this is done in the liver. There's a limited amount of enzymes that break alcohol down, and the quantities of alcohol that people consume completely overwhelm their body's ability to eliminate it. So it's a process that's limited by the availability of the enzymes. So it actually appears to occur as a steady state until the quantity of alcohol in the body gets down so low that it then speeds up. With THC, with cannabis, it's an exponential, rapidly declining function. So you will get peak, if someone smokes one joint, you will get a peak BAC usually within a minute or two of the cessation of smoking, if the person's puffing regularly. And it will drop. Within 30 minutes, THC level drops probably 80%. Within an hour, it's over 95%. So, but there is no good correlation. You get peak THC at points where there's no impairment observed. You get peak impairment at points where you virtually can't detect THC. So you have to clear your mind from thinking that there's some kind of magical per se level that will indicate whether the person's impaired. You find people at the same THC level who have show massive impairment or no impairment. So all we can do is say THC was present. We can't say that they were impaired.
Dr. Abrams.
Yeah, can you discuss the utility or validity of looking at fatal motor vehicle crashes in states that have approved recreational medical cannabis before and after as a marker?
Well, the challenge is most states weren't reliably testing and aren't still, so you don't have much before data. Both Colorado and Washington did not have really good data. Washington State did partner with my agency, and we did a representative roadside survey of the prevalence of THC-positive drivers. This was after their initiative was passed in 2012. It took them a long time to pass legislation and get around to retail sales, so we did get out and did waves of surveys. So we were out there before retail sales started, and then 6 months and 12 months later, and we did see a pretty surprising increase in the number of THC-positive drivers on the road. This was a representative sample. I can tell you we've been doing a national roadside survey all across the United States, a representative sample of drivers. We've started doing this in the 1970s to measure alcohol positive drivers. In 2007, I included drugs for the first time, and we most recently did this in 2013 and 14. And something's going on in this country without question. In 2007, I believe it was 8.6% of drivers had measurable THC in their blood or oral fluid. In 2013 and 14, it went to 12.6%. This is almost a 50% increase in 7 years.
See, what I was asking was, can you use fatal car, not regarding THC levels in the driver, but can you use trends in fatal car accidents as a marker for impairment or not?
No. They fluctuate due to a whole variety of causes. So we've had a very nice 7-year period of declining fatal crashes. Starting in 2015, they seem to have reversed course and they're now increasing. And this is all across the nation. We're not exactly sure why this is happening. But we see particular groups like pedestrian bicyclists that get hit with cars. Motorcyclists have been on an upward trend for quite a long time. There's lots of causes of fatal crashes.
Dr. Alegria.
Thank you so much, Dr. Compton, for a very interesting study. I had two quick questions. One is, was there a sufficient number of THC-only drivers compared to mostly being joint alcohol THC drivers? And two, could you quickly also clarify whether the adjustment that you did was only adjusting for the alcohol variable, or was there any propensity score matching or propensity score weighting that was used?
Okay. We actually did several different analyses. So, for example, we tried doing what's done with BAC and running risk analyses for high BAC versus high THC versus low. We actually just dumped them into two groups and had under 5 nanograms and more. We tried cutting off around 15. None of this made any difference. We did run only THC alone versus THC combined with alcohol versus THC combined with other drugs. No difference. We were surprised. I've funded studies before that showed the combined use of cannabis and alcohol leads to higher impairment levels. We did not see increased risk in this study, but I think the reason for that is the risk for alcohol is so powerful that it overwhelmed any potentially additive effect of marijuana. And the last part of your question was?
It's a type of adjustment, because I'm trying to understand the adjustment, whether it was just putting the alcohol variable in, and if your sample is mostly of people that both use alcohol and marijuana, you would wipe out any effect, unless you had a pretty big sample of people that only use marijuana only.
Actually, most of our THC positives were THC alone. Okay.
Dr. Cooper.
Okay, really interesting set of data. So it seems like there's a case here for not looking at THC plasma levels when thinking about if cannabis is associated with traffic injuries. So I'm just wondering, is there some other maybe a behavioral measure where we can actually look at and with some degree of certainty that somebody is intoxicated? Because again, THC plasma levels, it's out the window. It doesn't seem like a relevant variable. But in the lab, under acute dosing procedures, as you stated, it does seem like there are deficits in driving capabilities. So with regards to, is that a factor on the road? Would you say that there's any good behavioral measure that we can use?
I think that's a wonderful question. And we are conducting research on that very topic as we speak. But I suspect this will take a number of years before we even know if it's feasible or not. One of the challenges is, and I ran into this with alcohol decades ago, when there were attempts to lower BAC limits in the United States down to 0.08, and the alcohol lobby ran around the country lobbying state legislatures that this was unfair, that their clients could hold their liquor and were not impaired at these extremely high BAC values. And perusing literature, the way research results are presented are typically aggregated, group means, and so on, the statistics. They never present individual data. So I found very few data sets I could actually get my hands on the raw data so I could look and see if everybody showed impairment. You often only get, the mean of this group at this BAC was higher than the mean of that group. Well, you don't know if it's, 20% of the people showing a big effect and the other 80% no effect. So I don't know. There's reports of considerable variability for people ingesting cannabis in terms of impairment, individual differences. So I don't know if such a test can be developed. We are going to be doing dosing studies to look at it. And we'll
We
find
need to
out.
move on. Thank you very much. That was really fascinating.